He is a very famous figure in Egypt, and I hope that we are going to stick to the time. Everyone will be about 10 minutes, okay?
I'll be happy to stick to the time if I get my slides on time. They are working on them. Thank you very much for the introduction. Nice to see so many people in the room, and we'll have a meeting which is going to continue with a very nice panel session a little bit later. So my role here, and Pierre Franco said has been starting to be traditional to have a debate with him, is to say no. No, I cannot agree that every single patient that crosses your door and is a candidate for adjuvant chemotherapy is going to receive neoadjuvant chemotherapy. Oh, I'm talking so loud that I'm really making emotions here. I would like to thank some of my colleagues for some of the slides that I'm going to share with you. Obviously, and Professor Conti very nicely depicted it, and then for sake of time I will go very quickly, we have reasons to do neoadjuvant treatment. You know everything. And certainly we do count on the fact that neoadjuvant treatments might help us go faster in the development of adequate treatments in the adjuvant setting for our patients. We should have realized that the neoadjuvant setting is a setting which is quite variable, as we do have responses which are very frequent for the examples that are given to you of HER2 positive or triple negative tumors, whereas we do not have the same percentage for those that are luminal A's and B's. And the question starts there. Yes, we do know that there has been a meta-analysis that has been published in The Lancet, and you are aware of this, that has been the basis for decision by the Food and Drug Administration to accelerate the approval of drugs based on the neoadjuvant studies. And we did have some very interesting data telling us that indeed in the NeoSphere study there were quite a few interesting results, and these were taken into account by the FDA, and therefore provisional approval has been given to this type of neoadjuvant treatment. But maybe we should temper enthusiasm. Maybe we should, and of course the example I'm giving to you is the example of NeoAlto. With NeoAlto we were very enthusiastic. We said, wow, look at these complete pathological responses. This should translate. It did not translate into overall survival data. Yes, we heard earlier a very nice presentation that discussed a little bit why this was not true, but nevertheless these are the facts. Let me go back to St. Gallen 2013, and very soon we'll have St. Gallen Vienna 2015. Just to remind you that this was discussed, and the question was there, what is the aim of neoadjuvant chemotherapy? It is only to facilitate subsequent local therapies. Well, as you can see, the panel was split, and I believe today the panel would not be split. Everyone would say, no, there's much more to it than this. But then we have the question, if you don't achieve a pathological complete response, what are you going to do? And as you can see, the panel was really asking themselves what I'm going to do. Because after pathological complete response, no, we are going to do anything more. But what are you going to do if there's no pathological complete response? Should you give all the neoadjuvant treatment up front? The majority of the panel said yes, not everyone agreed. And if additional chemotherapy is warranted when the patient is not having a pathological response, what should be done? Yes, the majority said yes, but what? What? That's the question. Of course, for all the neoadjuvant treatments with HER2 positive treatment, we should use combinations with trastuzumab. And then there was a question at the time, we didn't have all the data, but the panel was still hesitant. And you heard Eric Weiner yesterday saying that, are we really going to use neoadjuvant treatment with the combination of trastuzumab and pertuzumab? Question mark. And then in the endocrine setting, as I showed to you, we do not get the same responses. It takes a long time to have a response. So how long should the treatment be? The panel didn't know. So you see the offers from the panel. So what are you going to do in your practice in that situation? What are you going to tell your patient if she has an endocrine responsive disease? I don't know what you're going to tell them. Maybe you will have the opportunity to look at Ki-67 in the tumor after a certain time of exposure to endocrine treatment. This comes from a question that I was asked yesterday with the Pictilisib study. And actually, there was a nice demonstration in San Antonio from the data from Mitch Dowsett that showed that indeed, for hormone treatment, Ki-67, when it drops to a very low level, is predictive of a very good long-term survival for these patients. But again, this is a study setting. This is not clinical practice. So my answer is no. It's not for all patients. Yes, it is in trials. Yes, for the traditional indications that you know of. But certainly, I'm very reluctant to offer this when I'm not certain that the patient is going to have a very nice response, because I don't know what to do for the patient, and the patient is going to be in terrible anxiety for months and years to come. Thank you very much for your attention.
Thank you, Professor Mashiapo, for this excellent presentation and for being very strict to time. And now, Professor Khalid will summarize. Okay. Now, as you have seen, the eminent two speakers, and we have data with yes and data with for no, and we would like to open the panel for discussion. Who would go for yes for neoadjuvant chemotherapy? And as we all know, it has been used really as a routine in this setting, and a very good percentage of patients get pathological response, and they would have less mutilating surgery. Yes, there is no impact in overall survival, but there is an impact on progression-free survival. So me, myself, I would like to be with the yes, but others will be with the no. So we can discuss it.
Well, I think we can postpone this till the end of the session. And now we will move to the second item in this session about chemotherapy will have minimal role in the era of precision medicine. This is going to be presented by two eminent professors, Professor David Cameron from UK. Professor Cameron is a professor of medical oncology at Edinburgh Cancer Research Centre and the University of Edinburgh in UK. And this is going to be for 10 minutes.
Thank you very much. I would not want Matty Apro to be tarred with